Thank you so much for your kind invitation. I'm very happy to be here for the first time. And of course, we speak a lot about glioma and brain, but I think that today the most complex question to solve is to know if Padova or Montpellier is the oldest medical university of medicine in the world, and we will have the opportunity, I'm sure, to discuss about that after the talk and around the glasses of wine. Connectomic view, why? Because initially I was trained by Bernard Mazoyer, who was my mentor in neuroscience, and I had the chance since the beginning not to speak English too early, but to think like a neuroscientist by becoming a neurosurgeon in parallel. And finally, recovered to see the glioma as a tumor mass pushing the environing brain. Very early, I had the opportunity to start to be involved in the so-called, at that time, networking brain, and finally connectomics and maybe meta-networking brain. And you can call it as you want, but to understand that a focal lesion, which is in fact not focal, can induce a reorganization at the level of the full central nervous system, including both hemispheres. Explaining why I would say throughout the talk I never understood what meant non-dominant hemisphere. But we have also to deal with the fact that the glioma is not a tumor mass. And now we have understood that despite the beautiful advances in neuroimaging, including PET scan, we are not still yet able to see the disease per se. Those networks, first of all, we have to break with the localizationist. And I know that everyone understood in the world that Broca's area is not the area of speech. Nonetheless, everywhere in the world, and I'm sure, maybe in this university too, you have professors continuing to tell you Broca's area is the area of speech. Okay. So, of course, you cannot break. I mean, just in 2025. So, in 2 months, I did 10 surgeries, not selected by other great neurosurgeons, especially in a university hospital, because they say it's not possible to remove this tumor, especially within Broca's area. And of course, we removed the pars triangularis and opercularis and part of the ventral premolar cortex, and the patient was well. Why? Because reorganization within and between networks. That means that, of course, it could be esoteric for some neurosurgeons, but in fact, this is very concrete, especially when you are into the OR. In other words, if you have the same lesion located within the same classical lobar area, with the same molecular pattern, and if you think that you will redo exactly the same surgery you did yesterday, I'm sorry that we understood nothing. Because in fact, the brain reorganized totally differently from one patient to another one. And what we have to better understand is what happened before to go to the operating theater, or just before to treat the patient, and not to go to the OR by telling, no, I will do a biopsy because I know we reached the limitation of neuroplasticity. What I like to call the backward modeling. Not just first seizure, day 0 is now. No, it's many months to many years, and sometimes maybe many decades after the start of the dialogue between the brain and the tumor. Typically, we demonstrated that when you have an insular low-grade glioma, which is very frequent, of course, I don't know why, but if you look at the contralateral hemisphere before any treatment, and maybe in patients with incidental discovery, you will see an increase of the volume of the contralateral insula in adults. So that means that morphometry changed. Of course, you have to know it in order to better understand how the brain reorganized at the level of the functional networks now. And then to say, of course, I can remove the left insula through Broca's area because everything is compensated thanks to the contralateral hemisphere or not. So once again, it changed from one patient to another one. Once you start to understand that, you will forget the disease because, unfortunately, we are not able to cure diffuse glioma patients. But you can remove a part of the brain telling you, okay, I reorganized before. And by understanding that, so applying this concept of neuroplasticity, and I was very impressed by Merzenik when I did my PhD thesis, but I said I would like to apply this concept to brain tumor patients, and it was almost 30 years ago. And in the meantime, it was absolutely critical to change also the model of brain processing, not only by breaking with localizationism, but by trying to model much more these dynamics. And sometimes, in real time into the operating theater, the brain is changing. It's a perpetual succession of new equilibrium states. Once you start to live with that, everything is much more simple, clear at least. Okay, beautiful sentences, but I've used some arguments. Yes, for the first time we published in the literature part, in a prospective collection of data, the median survival is now more than 20 years, not yet reached in low-grade glioma patient with preservation of long-term quality of life. So, by dealing with this brain plasticity and better understanding of the network, we changed radically the natural story of the disease, and this is the reason why, of course, I'm sorry, but I will never believe on what I did for at least 10 years, because I would like to see what will happen in 20 years, and in 20 years I will not be there anymore. So how we started to change now in practice everything 25 years ago by doing early surgery. The patient is well, we have not to operate him, her, because this is a benign tumor. I will remember to you that the median survival 25 years ago was 6 years. It's not really what I call benign tumor. Second, maximal resection. Are you crazy? You are removing the brain. It's a brain invaded by tumoral disease. This is the reason why it's a diffuse glioma. The WHO classification accepted that only 10 years ago, not 25 years. Third, safe resection. Intraoperative mapping. That if the patient is not hemiplegic, we're happy. No, we would like for them to return to life. And more than 94% of my patients are still able to work after surgery, which is not enough, to my opinion. I will not insist on the fact that low-grade glioma are becoming malignant in all cases. And more the tumor will be big when you do the diagnosis, more you will see some foci of malignant transformation. And you will see that in our practice it changed nothing, because it changed nothing on the median survival. But we said we have to operate earlier. Yes, but the patients are well. No. And we started to do cognitive assessment to demonstrate that they had some cognitive deficit at D0 for the neurosurgeon. But in fact, it was maybe 15 years after the beginning. So in more than 50% of cases, they have already some degrees of cognitive deficit in 1 to several domains. And of course, if you do not perform systematically cognitive assessment, never you will know that. You can tell me, you see, it's related to the lobar location of the tumor. No, it's related to migration along the white tract. Typically, you have an invasion of the I4 before surgery, you will see a decline very frequently of the semantics. But it could be verbal, non-verbal, multimodal, or modal, we can discuss about that. So we decided to do systematically a mapping, because I understand since the beginning, thanks to Bernard Mazoyer and George Hirschman, that we had different brains for the same age, location, tumor, volume, and molecular pattern. So we decided to do systematically an individual functional anatomy mapping, and of course I was involved thanks to Bernard in functional imaging. But I discovered when I went to the operating theater that it did not work, not at the individual level. Because what I would like as a surgeon now is to know if I can remove more of the brain invaded by a chronic disease. And when you have an activation, you cannot say today if it's critical for the function or not. In other words, can you remove this activation and be sure that the patient will recover? This is my question. It was my question 20 years ago. Today, I have an answer. So I will not rely on fMRI, even if will be the first to do a fMRI before and after surgery to understand mechanisms of neuroplasticity and to try to understand what I did and maybe to pre-plan the reoperation accordingly. DTI is not function. What I want is to know if I got it, then I will use this kind of deficit permanently or just transitorily. So I will not use DTI, and nonetheless, even if I was a little bit provocative in some meetings, they decided to invite me in Bordeaux in 6 months to deliver a lecture in the International Society for Tractography in order maybe to push them a little bit more by telling, now I would like to have something more helpful for me. Because it changed nothing into my operating theater. But in Boston, during the next Karolinska, everyone will say, yes, I would like to buy the new software by BrainLab, Medtronic, what you want. And it's just to compensate, I'm sorry about that, but the lack of knowledge of the functional anatomy. And a robot will never compensate that. This is the reason why there are no 20 years of median survival. Because, in fact, I'm very humble in front of the brain. And 30 years ago, almost, I decided that I knew nothing and that the brain will guide me. So, of course, brain mapping, of course, cortical and subcortical mapping, and of course, since, in fact, now 20 years, we started to demonstrate that it improved both externalization and functional results. Perfect. But it was not enough. And I said I would like for my patients to return to a real active life as human beings. So I have to take into consideration the job, the lifestyle, and so on and so on, the concept of à la carte. And I was obliged finally, because I had the challenge also to receive patients coming from more than 30 countries with different cultures, languages, and so on and so on. And vast majority of cases deemed inoperable. So you can tell me how you have bias in your series before. This is the reason why they are living longer and better. Of course, it's a selection of patients not selected for surgery elsewhere for 25 years. It's a bias. The brain taught me what I had to do at the individual level in real time. So, I would like for younger people to tell you that objectively, the best oncological and functional results, both, not just my patients are living longer, yes, but what's the price? Or they are so well, yes, but they are dying earlier. No. Have been obtained without any technology. Technology is dangerous. I hate technology. Into the operating theater, I love technology offline to better understand what I did. A posteriori also, every week I learn something more. And sometimes not during surgery. I say, oops, finally, the patient is well, but I have not completely understood what happened. And now I will try to better understand. Offline, but into the world, no navigation, no DTI, no fMRI, no robot, no microscope, no echo, no, okay, you understand. So, the reverse, is on the other hand, to know that I have not, especially for the first time, because it's easier to reoperate patients because you started to better understand not only the natural story of the disease after the first surgery, but also to better understand the interactions between the brain and the tumor. But the first time, you never know. So I will do systematically away surgery because I am humble. And the right hemisphere, I know that it's critical for complex movement, for driving, for non-verbal semantics, for executive functions, working memory, but also attentional processing, but also for emotion and personality. We do not care. You know, in the double-analysis meeting, what we will see is great surgeons showing slides with my patient is well, and they're happy with that. That's crazy. It was good 30 years ago. So into the world, what we did is to try to recreate the real life, and the real life is multitasking. And then we can adapt definitely by asking the patient to do movement plus language, but language could be naming with PPTT, but also self-evaluation, but also with time constraint, but also without any rest in order to monitor sustained attention, and so on and so on. But also switching from one language to another one. This woman, for instance, is doing one set in Portuguese because she's coming from Sao Paulo, and one set in English, and so on and so on. And of course, what happened when I removed the so-called Broca's-Arab? Nothing. Now, by stimulating the SL3 between the ventral premolar cortex and the supramarginal gyrus, the patient is completely stopping. Okay, the articulatory loop we have understood, so they have to stop. Before, you need an intraoperative MRI to know if there is a residue, but I know there is a residue. You will not get the SLF3. What? Okay. Knowledge of the anatomy. Reaction time. Why? Because if you start to have to think too much about what the name, I have it on the tongue, but I do not remember, then you will decrease very significantly your chance to return to work. It's a critical before. I don't know, you have just to ask the human being in front of you before to go to the OR. And she will tell you, yes, no. Okay, and I will adapt accordingly. And sometimes you push more. In the meantime, you can also start to build new model of cognition, not based on your imagination or statistics, but just based on what you see every day, every week into the operating theater. But speaking about the real function of the connections, and especially the wide matter tract. So very quickly now, what we have learned, just a mosaic. Broca's-Arab is not the area of speech, okay? And it's true in Montpellier, but it's true in San Francisco and also in Shanghai with ideographic language. Okay, we have understood. The connectivity is much more important. So you can do what you want into the OR. I mean, a panel of tasks, if you are a mathematician and calculation, if you are a lawyer, judgment, you can implement what you want. It's very long before. No, it's short. I had 1,000 visitors in 20 years, and they are all surprised because at noon I finished, even for a big tumor, because my goal is not to remove from inside the tumor mass. My goal is to disconnect the part of the brain I can remove according to the reorganization which occurred before I made the diagnosis. And of course, the personality, emotion. I think it's important. Without the same passion, I am not Hugues Duffau. So, do you want to preserve your personality? Strange, because I operated on many medical doctors, and the first question they asked me was not, are you going to kill me or to induce a hemiplegia or a failure, but you think that I have a chance to return to normal life, including to work as a medical doctor? What about the empathy? Strange. When medical doctors are sick, they are thinking about ontolizing. When they are speaking about patients, they are thinking about median survival. No, I'm sorry, PFS. It's enough. And then you can publish in New England and to say, we cured glioma. Are you sure? So, of course, I love tractography, FMRI, but also dissection, because we do not know the anatomy. I will say it again, especially for younger people, you will not know the anatomy enough. So you will try to compensate thanks to technology. But once again, it will not work, especially because guys who are programming DTI, do not know the anatomy. And I will show you, neurofascicular. We published in Brain just in the past 3 years. That's crazy. We know nothing. Speaking about movement, of course, if you go to the coronary internal capsule, the patient will be hemiplegic. Okay. But is it enough if you are a pianist or a surgeon? You need to have more complex bimanual coordination. We do not care. Now, you do not care. Are you sure the patient will really be able to live with that? Do you want to preserve that before? Why not? You have just to preserve the frontal striatal tract and or the frontal astron tract, and the patient by doing a task, okay, you stimulate, and you are not yet into the contact of the permanent pathways. So you can avoid à la carte to induce the supplementary motor area syndrome or not. So to answer your question, are you sure that you will induce deficit? It's really depending on preservation of some nodes. But differently after SMA syndrome we recover. I know that. I wrote that 20 years ago. But it's not completely true. If you want to have more complex cognition, I mean the willingness to do a complex action. How do you want to operate patients in the so-called right and hemisphere, posteriorly at the level of the parietal lobe if you have not only the somatosensory feedback, but also the awareness of your own body? It's not possible. So as surgeons, we can try to explain to oncologists, voluntarily it's published in Cancers recently, what means cognition. Don't worry, they do not care. What they want is to avoid hemiplegia, and that's it. But, once again, if you have a surgeon in front of you and you operate it, a lot of surgeons, low-grade element, what they ask me, do you think that I will reoperate after your surgery? So you need bimanual coordination, so you need connection. Interaction between networks. I move and speak. It's very difficult to do just one function in the ecological life. Speaking about speech, the frontal ascent tract, I will not insist about stuttering. You can induce into the oral and you can decide to cut or not. It's really a la carte, according to the wishes of the patient. Recently, I have seen a guy who is a very famous TV presenter. So you imagine that he cannot have a stutter. If he wants to continue to enjoy his life, he will say, my life is to be a TV presenter. Okay, so I start according to the fat. And sometimes I cut the fat in some patients. If I have some difficulties at 65, I retire now. What I want is to live longer. Everyone knows, of course, the arcade fasciculus. We spoke about that just before. No. 3 years ago, we published in Brain the functional anatomy of different supports of the arcade fasciculus and working all together. How do you want to see that in the new RenLab software? But we do not care, especially the cortical combination. I will apply the same concept with the IFOF. I know that, of course, the IFOF will induce semantic disorders when you simulate. I wrote that 20 years ago. But I have a regret to tell you that I didn't know the functional anatomy of the IFOF. And we have published just this week in Brain the functional anatomy of the IFOF. And don't worry, I have understood nothing. Because we have to continue to apprehend the complexity of the main critical pathway in human. How do you want to operate the brain, especially the insula? But today I will stop according to the IFOF. But what do you mean about IFOF? Especially because when you stimulate, we have nonetheless to remember that our goal is to induce a transitory deficit. We could imagine that 1 + 1, 2. Dorsal pathway, ventral pathway, I will induce anomia. No, it could be jargonophagia. Ask to your navigator to tell you I am at the junction between the arcade and the IFOF. I know that. Jargonophagia. Okay, I know. I have to stop. There is a residue. Yes, it was expected. The ILF, inferior longitudinal fasciculus, the lexical access. If you have an increase of reaction time, just that, you know into the oral that patient has a high risk not to return to work. So you have to stop. Don't worry, you will come back. In Brain, thanks to Emmanuel Mondonnet, we published last year a new fasciculus. We know the anatomy, we have understood it before, so we do not need to continue to perform dissection. Really? You think we know the anatomy? The 4 support of the Arnold bundles may be involved in lexical access, but we are not completely sure. That's crazy. We are really not humble when we say that we know the functional anatomy of the brain. And nonetheless, we continue to operate the brain. No, in fact, what we are doing is within the mass. And we continue, the second slide of this talk, finally, to try to see the tumor, to debunk the tumor. But it's not brain surgery. And it will change nothing about the history of the disease. We are doing surgery for nothing. You can play piano or to do something else. You have to remove differently the brain side, or not, and sometimes to say just a biopsy. I will not insist for reading, for cognition. When we published the first paper about the new network of language revisited, I mean with the function of the wide matter tract, you cannot see that using DTI and so on. They said, but you mixed language and cognition. Of course, you want to speak about language without non-verbal semantics, executive functions, attentional processing, and so on. Yes, yes, but you have to simplify before. No, the brain is complex. We have not to simplify. So, we have to be honest with ourselves, and 20% of my patients continue to have some degrees of cognitive dysfunctions regarding the working memory, the mental flexibility, and so on. So we would like to increase this level of knowledge, but we did not completely reach today, knowing that 50% already had some degrees of cognitive deficit before surgery, remember too, and we have to incorporate that. The brain is telling you before to go to the OR, be careful, I started to reach my limitation of neuroplasticity or not. Cortico-subcortical pathways, so interactions within networks, between networks, cortico-cortical, cortico-subcortical. Projection, I would say we do not care. If you cut them, of course, the patient will be hemiplegic, so everyone knows that. We are far beyond just projection fibers now. Optic tract, we spoke about that. Do you want to continue to drive? Yes, no. My patient is well, is not hemiplegic. But it's not driving anymore. He lost his job because of your surgery. I am responsible. Spatial awareness. Another level is your spatial, not just visual field deficit. We published, thanks to Michel Thiebaud-de-Choten at that time, the SLF2 and to avoid neglect. But it was just a start. More recently, we started to understand a little bit more how to avoid, at least to try to prevent some visuospatial attentional deficit, especially by also taking care of the SLF1, but also cingulate. It's very rare in my talk to speak about one fasciculus corresponding to one function. Otherwise, it's a kind of localizationism of the connectivity, and it does not work like this. The right non-dominant hemisphere, which is nonetheless, I'm sorry about that, but critical for semantic cognition, but also for mood. Of course, we do not care who is doing mapping of mentalizing into the operating theater, except Japanese people, in addition to us. Because in Japan, they need much more than us, it seems that. This social cognition, and this is the reason why they were enthusiastic when they came to Montpellier, while American people say, never will administrate this kind of task. We do not need empathy in real life. Okay, perfect. So once again, I love to suffer, so I asked to my neuropsychologist, despite good results, patients are living longer, better, and so on. Are you sure that they did not change, modulate their personality, mood, behavior, and so on? And my neuropsychologist, knowing what I suspected, of course, will change a little bit with more irritability, disinterest, and so on. Can we change something into the OR, especially in the right so-called non-dominant hemisphere? Yes, of course, by administrating tasks based on the recognition of emotion of faces in front of you. But it's too long before. They will live 20 years. Maybe it's important for them to continue to have normal social cognition. Are you sure that by doing that you will preserve social cognition? I'm not sure, but we changed radically, and we started, and we will not insist about that, to model the two levels of mentalizing the lower one, I mean the recognition of emotion, and especially the role of the arcuate fasciculus, including the right so-called non-dominant hemisphere, plus minus the alpha, blah, blah, but also the higher level, the inference of intention of people in front of you. And of course, the cingulate bilaterally, and so part of the deformant network. And if you start to have a desynchronization between you can induce a kind of autism. And now, finally, 20 years later, 15, psychiatrists started to be interested by this kind of model. You can increase the level into the hour without increasing the time, the duration of surgery, by asking the patient to self-evaluate. But he's doing already a semantic association task with naming, moving every 4 seconds by switching from one language to another one. Yes, and I will ask him, her, in 4 seconds. In our experience is 1 to 5, and 1, I don't know, random, I said something totally wrong, and maybe you stimulated, so just in 1, you have understood, versus 6, I'm sure. And of course, it's very, very impressive when a patient is telling sadness for happiness, 6, because I know the melody. How do you want to continue to enjoy your life with that? But we do not care because the patient is not eliminated. You can take the picture after that. That's crazy. So, yes, dissection is very critical because we made some dissection in the period in Montpellier. But now I'm happy to know that it will be in Padova. And I was not in the same patient, but correlating specimen, sometimes DTI outside the operating theater, and the intraoperative mapping demonstrated that the right and left was involved. And I cannot tell you more. This is the reason why you have so many works to do by yourself in both low level of mentalizing, non-verbal semantics, and so on and so forth. Okay, personality, I will not insist. So what means the right non-dominant hemisphere? I'm never so afraid when I have to operate within non-eloquent areas, because I don't know what I'm looking for. When you are in so-called Broca's area, you understood that around Broca's area, and especially in the depth, you will finish to find crossing fibers between the dorsal and ventral pathway. You will stimulate, and then patient will have some Japanese aphasia, a little bit more in the temporal lobe, if you remove the insula and semantics, a little bit more in the dorsal pathway, and the patient will have phonemic and or phonetic paraphasia, and everyone will be impressed in the operating theater because how he did that without your navigation. It's just an evidence, very clear. But in the right non-dominant hemisphere, it's a nightmare. So to make it more concrete from your surgeon, I compared Duffau to Duffau. Duffau, when I was younger, I did right insular low-grade element anesthesia. And not so bad, finally. But 2 permanent hemiparesis, return to work about 80% and so on. And a really severe depressive syndrome, and we never forget. So I decided to do awake surgery since now more than 15, almost 20 years, systematically in the right so-called non-dominant hemisphere. You can see by yourself. Return to work more than 95%. No permanent neurological changes. Yes, but you left more tumor. No. I cannot believe it, Duffau. Okay, it's your problem. It's just because you do not believe on the reorganization and the dynamics within and between networks. So you can operate more, at least with the same extent of resection, because I started when I was younger very extensively, and finally it preserved the quality of life. So we did a meta-analysis of the literature for neurosurgeon recently in the right so-called non-dominant hemisphere for low-grade and high-grade glioma, and patients operated on under local anesthesia have a better quality of life. So why it's not done systematically? We have evidence-based medicine before. You have evidence-based medicine. Yes, but we are not interested. Okay. So, the outcomes. Otherwise, I cannot say I do not believe on what I did. I want to see numbers with long-term follow-up. When I started survival 6 years, it's not my imagination, it's evidence-based medicine. And the quality of life is not evaluated. Patients, just numbers in oncology. So I did more than 1,000 diffuse low-grade MRI created within so-called eloquent areas. I understood that, in fact, they were not eloquent anymore, of course. So Broca vertically behind the labellate, as you can see, around the system, corpus callosum, blah, blah, blah. Mortality 0. It's not expensive to have a good team. Good anesthesiologists, good neuropsychologists, speech therapists, all of them a PhD, doctor now, in neuroscience. You cannot be a speech therapist with me if we cannot speak the same language. 0.15% of cerebral problem deficit when I was younger because I pushed too much in the right, so-called non-dominant hemisphere, I understood now. 86% of cognitive preservation, which is unique in the world, first of all, because no one is doing pre- and post-operative cognitive assessment systematically since 20 years. But also 10% of cognitive improvement. I know that in a meeting at neurosurgery is very frequent. Listen, colleagues telling me, you cannot tell me that you remove the super because the right patient is better now while he was well before. But he was not well. He had some verbal working memory deficit according to the extensive cognitive assessment. He was well according to your criteria. Second, I preserve the connectivity, which is the limitation of the neuroplasticity in the deck. Explaining why neuronavigation does not work anymore because the brain shift in the end. Third, we did a post-operative cognitive rehabilitation systematically by preserving the cognitive reserve. So why not finally to be better 3 months later? Why not? 94% of return to work, definitely, which is not good enough for me. And now 85% of positive impact on epilepsy. In order to convince everyone, and this is the reason why I hate this classification, I was obliged to use this classification to publish in the Lancet series. That means that 400 patients do not exist anymore because news. We cannot know exactly if it was a wild type or yes, no, IDH mutated because you operated on them 15 to 20 years ago. I'm sorry, they're still alive. Sorry for them. Yeah, but you cannot include them in Lancet. Okay. So I will do just with IDH mutated. Prospective data. Overall survival more than 20 years. Not yet reached. And strange because it's not a drop. They will not all of them die. In fact, we stopped the collection to publish this paper already 2 years ago, and they continue to follow that. How is it possible, different? You continue to die, patients still alive. But because now we can do radiotherapy, but you cannot irradiate the brain. You are the first to say that. But we never irradiated the brain in these patients, explaining why they are well. You have seen 1%, less than 2% of early radiotherapy. But it's against the protocol. Yes, it's strange because 10 years ago you said, we have to irradiate. And now you are telling you have to give fluorescein and to avoid to irradiate. But patients were irradiated, and now you are telling, oops. Is it possible to change what we did? We forget that. The most important is a prospective collection of data from now. No, I'm sorry. We say that for one generation, I would like to see the results everywhere in the world. We have these results, so I will rate them up. We should be honest by telling this is the median survival and this is the quality of life. Yes, but it's related to molecular biology. No! Of course, it's better to have an oligodendroglioma than an astrocytoma than to have a glioblastoma. But whatever the molecular pattern, you will check radically the natural story of the disease by doing a more complete resection. What do you mean, more complete resection? By doing, if you can, supratutorization, because sometimes the brain is telling you, I reorganize myself, please push more. So we use a propensity score matching analysis, blah, blah, in order to demonstrate that, of course, in supratutorization, the vast majority of patients are still alive with more than 20 years of life. Yes, but the price to pay is to have a cognitive disorder. Okay. We published in Brain past year 400 patients with cognitive assessment with complete and supratutorization. We compared no difference in their well. No, we demonstrated. I would like to see that with voacidity. So in 10 years, maybe. I have already 20% of patients with growth under voacidity with 2 years of life. It's crazy. In addition to, of course, we had a good impact on epilepsy. Was identified as no. They started to say, yes, maybe, no, not maybe, sure. We published that in Journal of Neurosurgery regarding the most extensive series ever published for insular Olympic low-grade glioma, more than 300. And you can see that more than 96% of them returned to work. And of course, with the long-term follow-up, with increase of median survival. The most important for me is to demonstrate that we were going to preserve an active life for at least 15 years. Why only 15? Because the tumor is recurring. And I cannot cure the grade glioma, diffuse glioma. I'm very sad about that. So we will try to push more, how to continue to improve. And I think that it's much more your questions for the new generation. First, to arrive earlier. When we have a chance to see a small tumor, especially incidental discovery, yes, we were crazy when we started to say that we have to operate in an asymptomatic patient, which is different because sometimes the cognitive scores are not optimal, while the brain did not yet complain by telling you seizures. Then in this case, of course, you have almost 60% of total or supracauterization, and of course, longer survival. And 97% of them resumed their employment. This is true in Montpellier, this is true in San Francisco, this is true in Udine. Thank you, Tamara. But even with supracauterization, I cannot cure them. After 5, 10, 15, 20 years, you finish to see this rim of hypersignal. So we will wait. And at that time, of course, what we accumulate regarding fMRI, DTI before and after surgery is critical because it's to try to better understand mechanisms. And especially if you remove SMA proper with voluntarily or not induction of SMA syndrome, then you will see after recovery the contralateral activation. Everyone knows that. Okay. But what was more exciting for us was to see the interaction between hemispheres. And when the patient had a transitory deficit, then you can see a decrease of the inter-hemispheric connectivity, functional connectivity. When they recover, you can see a real increase. So be careful when you remove more or less the corpus callosum in addition to the SMA proper. Now you start to have some limitation during the first surgery, and maybe to push not so much. But in this case, because this is not an output or input, you know that you will come back. Typically, the so-called club of the hand, I was not able to remove it during the first surgery. Of course, I stopped because the patient is a guitarist, and of course, no radiotherapy, blah, blah. And finally, when we came back, because you can see that 5 years later, the fMRI started to show you more contralateral recruitment, but also a jump from the precentral sulcus to the central sulcus. I came back, and finally, when I stimulated the same area, nothing happened. And I removed it by preserving the connectivity. So what means the knob of the hand? What means Wernicke's area? I removed it 10 years later. Why? I was not able to remove it during the first surgery. I hate to do this, so I will come back. I preserve the connectivity. By frontal lobectomy. No, I cannot believe that this patient is not well. Okay, but 3 hours of cognitive assessment published in Brain and Cognition, including regarding the metacognitive abilities, and so on and so on. And it was able, first of all, to take care of his family, to drive to work and so on. But of course, I did not perform bilateral frontal lobectomy in one stage. I came back 10 years later when the tumor had the good idea to go through the corpus callosum on the contralateral hemisphere. So 2 years ago, we published again in Brain the first try to better understand the different patterns of reorganization. After your first surgery, by comparing the map during the first and the second surgery, to make a long story short, you know what is the most plastic area in the brain? Broca's area. I did not perform the statistics by myself in order to be objective. Now, to be more concrete also, what means grade 2? For a long time, as we said, we considered that it was a continuum. So we published this paper with 3 consecutive surgeries, each time by removing more brain, each time patients recovered because in the meantime new mechanisms of neuroplasticity, by combining 2 and 3, median survival 18 years, preservation of quality of life. So it's not 20, but not so far. And I can tell you that in the vast majority of beautiful series published in New England and Lancet about grade 2 glioma, there were a lot of grade 3, except the fact that patients were not operated on, and the surgeon did just a biopsy. You can imagine, under quotation, in at least 50% of cases. But we are not interested by this kind of consideration. Really. To be objective, we continue to do systematically cognitive assessment after reoperation, exactly the same scores, especially 94% of cognitive preservation and 94% of return to work after also a third surgery. This is the reason why we have published an atlas, of course, which is only probabilistic, by telling you have this chance to recover after brain damage, not only to predict the consequence of a surgery, but also after stroke or beyond. And I would like, especially to neurosurgeons, to explain why I do not use microscope, because I have seen so many great neurosurgeons in my life in different countries and continents under microscope, finishing to remove an insula beautifully better than me. I'm not so skilled. And they found the tumor in the depth. So they would like to remove just a little bit more, 3 more millimeters in the depth. Yes, but you know that you disconnected, in fact, 1/3 of the hemisphere by cutting the part 5 of the I4. You can see the inactivation, disconnectivity between 1/3 of the hemisphere by cutting 3 more millimeters. No. Under a microscope, you are blind. It's exactly what happened to radiotherapists for a long time. If you do resection according to the connectivity, which is the limitation of neuroplasticity, when they have to irradiate, they irradiate the critical networks. Yes, but we are not totally idiot, we are not going to irradiate the full brain. You do not care. You will irradiate the crossing fibers between dorsal and ventral pathway. Even if you focus at this level, to your opinion, what will happen? Decline of cognitive functions. Yes, but we increase the PFS. Oh, it's very exciting for patients. They love to know that the imaging is stable. But what they would like is first of all to remember, and better, the PFS is not a good surrogate of median survival. I will show you again. Van den Bent et al. Lancet 2005, the PFS increased, but the survival is the same. It's exactly what they are telling today for vorasidenib. So I will only take care of survival. You know that in our paper, in Lancet, they absolutely asked for the PFS. We do not care. We gave you for the first time the median survival beyond 20 years. Yes, but we want to have the PFS. To be honest, my chief resident calculated the PFS. We put it in supplemental data. I don't know where it is, and I don't know the number. I do not care, because my patients do not care. But it was the price to publish in Lancet, to give the PFS. But you have understood that it's, sorry, but a wrong surrogate. We do as medical doctor. But the cognition is destroyed by early radiotherapy. No, you exaggerate before. Okay, it's not from Montpellier. 50% of patients within 5 years. My patients are living 20 years. You imagine to live 15 years with decline of cognitive and emotional function, even if no one cares about the emotional patients. What do you propose different? To operate to reoperate if it's possible, if not, to give chemotherapy. And to keep radiotherapy, because now I am the first to say you have to be irradiated, but 20 years later, because I cannot reoperate, and we used chemotherapy twice. Yes, but chemotherapy will induce decline of cognitive functions. No. We published that chemotherapy is preserving the cognitive functions. I would like to see that for vorazide too. Typically, because I needed to be older, we published recently a paper where patients operated on 4 to 5 times, but not because I expert, but because preventive way, and 20 years later, they're still enjoying normal life. And the vast majority of them are not yet irradiated. Otherwise, you cannot. If you start to irradiate the connectivity, of course, you will see a decline of the neuroplastic phenomena, and you will not be able to reoperate. Or at that time, when you will reoperate, the patient will not recover. To conclude the oncological issues, because we understood since 30 years that the goal was not to do biopsy, but to remove the blood as much as we can, we identified in more than 50% cases some fossil malignant transformation. So what means grade 2 glioma? But today, in the classification, if you have one focus of grade 3 and for grade 4, you have to consider that it's a glioblastoma and to do 2. But really, we did not. We are crazy before. You see the 5-year survival rate, more than 95%, with of course preservation of the quality of life because the patient did not receive any adjuvant treatment. So if a tumor was so aggressive, the patient should die. Is it possible to change so radically the natural story of the disease? Of course, you have just one focus. So we have to change the classification again by telling we have to take care about the heterogeneity of the glioma, intratumoral heterogeneity. No, we are not interested by that. Okay, we are interested. This patient now is under radiotherapy, 23 years later. Why? You can see the enhancement she had, but I did a supratorization at the time. We published the sole paper, neurosurgeon now, with low-grade glioma more than 100 cc. Giant. Of course, in the vast majority of cases, you find some fossil malignant transformation. So, I know I was a little bit provocative, but I had good reasons. No survival difference between grade 2 and 3. If, of course, you left so few residual tumor. This is the point. And of course, what you left is not high grade. I'm not speaking about high grade foci everywhere in the tumor, just in the middle. Yes, but according to the classification, we have to consider it's a high grade glioma. No, we will not do radiotherapy. I'm sorry, and our patients are living longer than that. Is it true for very high grade glioma before? Yes, I trained younger people, like cerebral, and finally they reproduce exactly the same results about high-grade glioma because they are more frequent, of course, by doing supratorization according to the connectomic, blah, blah. You can see that themselves, that they say that the patients are living longer than them. So we have to tend to more causation of the flare in high-grade glioma. To really conclude, but showing that we do not care about the quality of life of patients. I'm so impressed by the return to work. Of course, they have between 20 to 50. What are you asking to the patient when you meet him for the first time? How old are you? Are you married? What is your job? It's not important in life. Less than 20 papers in the full literature. Thousands about molecular biology. I would like to see their results. What about the sexual dysfunction? 3 papers. It's not important between 20 and 50, of course, because the patient is like this, so we're happy as well. 3 papers, including 2 from Montpellier. But we are very interested by the quality of life of our patients. Really. Creativity. I love art. So I will publish paper for neurosurgeons in neurosurgery about the fact that it could be important when you are an artist to continue to practice your art after surgery, like a surgeon who like to reoperate after your own surgery and so on. And you can see that I made some mistake because I changed very significantly by doing this frontal lobectomy, including the corpus callosum, blah, blah. But also the deformable network, I did not understand at that time, explaining very likely why from mysticism she became a cubist for 15 years, a very famous painter in France. So how to try to model that, to be honest, I don't know. But I know the way. I mean to think in 5 dimensions. The 3D, of course, the structure with the cortical termination and the sublayer of each pathway. The 4D, the brain reorganized before surgery, it will reorganize during and after surgery, or radiotherapy, or chemotherapy, or just by doing nothing, by looking at the tumor growing, migrating, and so on. But the 5th one also, what could happen if I would like to change, reorient the pattern of reorganization of the brain, for instance, from perilesional to contra-lesional, because, of course, to open the door to reoperation much more helpful. And at that time, to know that the brain is changing all day long is very good, except if you have a risk is to become crazy, because here you have more or less my mental imagery. I mean 20 domains of cognition with the critical, cortical, subcortical networks. And it's exactly what I can see when I am into the operating theater, even if, once again, every week I learn something, I miss something. But you can incorporate in the model. You imagine the neuronavigator giving you this kind of information. This is the reason why, by applying this concept of 5 dimensions, we started to try to really model and predict how much the patient can recover or not according to what we call the connectotomy. Of course, a kind of disconnectotome a priori, at the individual level. And of course, to achieve this kind of ambitious goal, we need to put not only stimulation at the level of the cortex in a way that tracks the function to the fMRI and DTI, exactly what we did recently, and there is another paper submitted with the team by Silvio Savio. And finally now, we can really start to predict when we will go to the order externalization. And to demonstrate that, I started approximately 10 years ago to say in after the first meeting in my report, I will leave this volume of the tumor according to this pathway and so on and so on. And to be honest, that works in more than 90% of cases. So if I can do it, you can do it. You should, as brain surgeon, by understanding the limitation for recovery, but by understanding that into the OR, if a patient is doing multitasking and then just have an increase of the reaction time, it could be enough for you to say, I will stop. Because you have seen during the stimulation that it was not the pyramidal pathways, not the language pathways, blah, blah, but you disrupted the interaction between networks, so the behavior of the patient. So you will not return to normal life. But once again, you can push according to the patient, what the patient decided before surgery, à la carte. And finally, we can adapt also the rehabilitation according to the reorganization of the network and not only according to the symptom, because you can have more or less the same symptom, but with different mechanistics underpinning the fact that you have an increase reaction time for the lexical access, for instance. And according to that, yes, the question very frequently raised by a neurosurgeon, I know when to, I can predict when I have to reoperate on my patients before making a transformation, even 20 years later for the 5th time. And my dream would like, of course, to use this 5D dimension by using not only rehabilitation, but maybe TMS, or TDCS, I don't know, but in order to push away from the so-called tumor, even if it's more diffuse, and especially in the contralateral hemisphere, before to really reoperate. The take-home message is that I do not rely on so-called evidence-based medicine based on randomized trials, because I have seen in 25 years 5 different periods, including you had to irradiate patients, now it's down, and finally, oops, no, it was not a good idea. Second, you have to adapt at the individual level by trying to understand the past before to predict the future, and not, oh yes, I did that yesterday, I will reproduce the same thing. If you think that, you know that you will do the wrong surgery. Third, to keep adjuvant treatment in reserve, you have to try to anticipate 15 years in advance. 20 is difficult for me. Less than 10 is a big mistake. These patients are living 20 years. So you have to keep in reserve if I cannot really reoperate. If we stopped at the migration thanks to temozolomide, and now maybe thanks to vorazide because 10 years later, is it still possible to continue to irradiate after 25 years? And I know that we will see a decline of cognitive functions, but infinite patients will live 30 years. It's exactly what I try to model now for my patients still alive. In other words, 75% of patients are operated on. And this is the reason why I love the current guidelines in neuro-oncology, because never they will speak about the brain. Never they will speak about the functional anatomy. Never they will speak about networks. Never they will speak about the connectome. Never they will speak about the neuroplasticity, just the survival. But by integrating this plastic potential in the brain, the patients are living longer. This is the concept of connectomic neuro-oncology based on 20 years of anticipation, if you can. So, I would like to thank the neuroscientists, especially the founder of the Human Brain Mapping meetings, Bernard Mazoyer and many others, because I had the chance as a young neurosurgeon to think totally differently, and you will see the school for a brain surgeon to try to understand a little bit the brain. Yes. Finally, the good news is that works. So please, for the young people, be neuroscientists first. And you will see that just to remove a part of the brain by using subparial dissection, even within the insulin to the contact of the ciliary fissure, you will have less than 1% of severe permanent complication. So that means that you will succeed if you know what you are doing. But most of all, you have to go beyond our results, which are unfortunately not yet reproducible in the literature, because if you continue to see the tumor in isolation, you will fail. Thank you so much.
Okay, thank you so much for this inspiring lecture. For me, I think you are totally on the spot. That this is what I say about rehab. That we cannot rehabilitate the brain like me, and you're saying that you cannot be a surgeon without being a neuroanatomist and neurophysiologist. I think that's really quite an important concept. So, are there any questions about this wonderful lecture? Any questions? Maybe some of the young people first, and then we get to the first rows.
When I stimulate too much, I can induce seizures.
Okay, here we go. First.
I mean, I just wanted to make an observation on what you said about our, relationship with technology. I started with a lot of technological advancements in neurosurgery, so I'm not used to the old way of making surgery. But what you actually made me think about is how much of a confirmation bias we have sometimes when we are approaching surgery in the OR, for example, trying sometimes to convince ourselves that by using different technological means we may achieve a different result, even though there is a superstructure problem in our mind. So I think it's actually really interesting working not only on the patient and the technological advancements, but also on the mindset of the surgeon that is performing the surgery. So yeah, I really appreciated that. Thank you.
The technology should be a didactic tool. I was probably one of the first to use neonavigation in the world because we had the chance to receive it in Saint-Pétri Hospital when I was in Paris more than 30 years ago. And seniors were not so interested to learn technical issues. So I did more or less own surgeries by myself when I was a young chief neurosurgeon. But very quickly I understood that it was a very good tool, for instance, to push my mental imagery by telling, before to put the neuronavigator, I have to push me to see where is the metastasis, for instance. But I mean through the skin, and to say, this is there. And then you can take the neuronavigator as a validation, that's it. And one day you will see that you do not need the validation anymore because your brain is better than your navigator. It happened last year. I used it one time, and the chief resident did for me now because I do not like technical issues. It was a small cavernoma, and I said, no, a cavernoma is much more posterior. And everyone, of course, laughed by telling, okay, he doesn't want to recognize. And finally, the navigator was not well calibrated. I don't know. So that means that if you use it to build your own mental imagery, and of course, it's exactly what I'm doing before after surgery, using a variety of hands-on analyzation, then it's beautiful. But if you become prisoner, I did so many visiting professorships, and one time in US, I will not say when and where, but they said you will have a full amphitheater today because the navigator is broken, and so on. And we postponed many neurosurgeons. And I said, can I see the first file? If you want. We can go to the OR and we remove it with the finger in 5 minutes and I will give my talk. So they are dependent, prisoner. And when you start to be afraid because you have not your psychotherapy into the OR, which is wrong, it's not very good. So think about that now, after that it's too late. Thank you.
Okay. More questions?
Yes.
Yeah.
Well, Hugues, I am very happy to see you again here in Padua. And I love the passion that you have in this field and your great knowledge in brain function. When you decide to go back to surgery, you decide according to what? How do you schedule the timing for new surgery?
So the equation. First of all, the brain itself. How are you? Are you enjoying your life? And sometimes the patient is telling, I'm too tired this year in comparison with past year. Maybe limitation on your plasticity due to the diffusion within the wildlife tract. We will do another cognitive assessment now. And if the brain is telling you, be careful, I start to suffer, unfortunately with new seizures, you know that you have to reoperate now. The brain is telling you, be careful, the tumor will become more aggressive. Second, the natural story of the disease. I mean by calculating by yourself the volume, the growth rate, and the pattern of reorganization of the tumor itself, because the tumor is very intelligent, and sometimes more or less bulky within the insula. It will be complex because the scar, the vessels, no, it's very easy. Versus diffusion, like the patient we have seen, 72-year-old, the U fiber of the SLF, arcuate, we have seen also beautiful. Okay, forget it, you will not be able. So please do chemotherapy first. I can be the first to say to my oncologist, please, give chemotherapy and try to induce a shrinkage, just the periphery, the depth. And I will, again, reoperate without compromising the quality of life, thanks to decrease of the volume. Third, the volume. Sometimes the patient is well, sometimes the tumor is growing very slowly, sometimes the tumor is not diffusing, and now we have to make a decision in a continuum, which is probably the most complex. 10 cc. That works so much. Berger told me that 30 years ago, and we were producing in France, in Germany, everywhere. 10 cc plus minus 5, according to molecular biology, if you want now to refine a little bit in a continuum, prevent really in more than 90% cases to see malignant transformation. Then you have just to convince patient to redo the surgery. Why? Paradoxically, they are well, and the tumor is growing so slowly, and this is the reason why the vorazanib is not well tested, because in these cases, it's too easy. You have just to reoperate. And fifth, the willingness of the patient. Now I have already scheduled some third surgery 15 years later in patients who would like to finish something before summer. And by telling, it could be very painful for me for my career, or because I would like to get married, blah, blah. So is it possible not to wait for 6 months in order to find a good oncofunctional balance? Of course, we will redo another MRI in the meantime, but if no modification of the behavior of the tumor, this is already scheduled for beginning of July. So if the patient is motivated as a human being, he will be longer.
Daniel?
I have a question about neuroplasticity.
Voice.
I have a question about neuroplasticity. How's the reorganization of the emotional and empathy pathways in patients with lesion in these ways? And how's the rehabilitation before, and also the evaluation before and after the surgery? Also from a quality of life point of view.
No, we only started now to model what I have shown you. I mean, according to the fact that some patients kept some degrees of deficit after my surgeries when I was blind, especially under general anesthesia, the right so-called non-dominant hemisphere, then we started to model the balance between the low and higher level. And we decided so to introduce more than 10 years ago some tasks into the OR in order to decrease the rate of permanent deficit, long-term deficit regarding modification of the behavior. And that worked. But now you're asking me the mechanism underpinning the reorganization of the mentalistic network.
Yeah.
You will achieve that, I hope, because we are starting. It's unless. It's a very good question, but we don't know.
Okay, and I have also a second question. In your experience, do you have had a psychiatric patient with a comorbidity, with neuro-oncology comorbidity, and what were the effects on consumers in emotion, for example?
What kind of comorbidity, like depression or
Depression,
bipolar
maybe
disorders?
psychosis or personality disorders.
I hate to treat patients with psychiatric disease. It's totally different. I mean, speaking about they have another real pathology, and they are followed by psychiatrists. And I know that because when I was younger, I was not aware about that. And you have seen, I mentioned, one guy who had a very severe depression. But I mean, who stayed at home after my surgery for many years. And I must acknowledge that. I'm afraid about that. I understood nothing about psychiatry. I work more and more with psychiatrists, but I am not ready for me to take this risk, to decompensate the psychiatric state, psychosis, depression, or I want, knowing that I will not cure the patient. And in this case, it's philosophical. But it happened now in these past 10 years in 5 patients. I preferred to propose biopsy and chemotherapy. And I know that one guy was operated on everywhere by it's right, non-dominant hemisphere, blah, blah, and it was a nightmare.
Can I? So, of course, it's been a wonderful gallery of a combination of localization studies where you assign function to specific fiber tracks, and combination of techniques, generation of atlases, and then you have this compounded survival data, which are kind of saying, well, awake surgery, which is a combination to some extent of all these things, right? And of course, in your position, with your experience, I'm sure you can do the menu a la carte, right? And I'm a little curious how the la carte is developed, to be honest, because, what kind of planning is it done on a particular patient, and what tasks do you do in the OR? That would be, and so what is your level of decision making, and how much, how many tasks do you have? But let's suppose that we want to replicate a Dufault-like program in another place. And so, what would be a typical workup for a patient? Because, are you getting, diffusion MRI with subject? Are you getting fMRI? Of course, it's a long question, but the point is, what are the ingredients, and can you come up with a menu that another restaurant can cook? Because I think that's very important, because otherwise it's a unique pinnacle of excellence, but the communicability of some of this, it's difficult. So I'm challenging you a little bit, okay? But if, let's suppose that we want to do in Padova a Dufault-like program, what are the elements and ingredients of such a program?
Exactly what I said at the beginning of my career, and I have a habit to answer in meetings of neurosurgery, US, Europe, and so on, China. You have to do a PhD in neuroscience. Otherwise, it will be just a tool. And you will not be able to replicate what Dufault is doing because you have not the mental imagery. And the mental imagery was built online because I mixed, thanks to Bernard Mazoyer and others. But this is the secret. And the problem is that...
Well, we know networks here. I think we're pretty good about networks. That's not a problem. The question is how to, I think that, the way of thinking about the anatomy, the functional anatomy, we're quite sophisticated here, okay? The question is, what are the elements?
In the mind of the neurosurgeon in real time, by changing the plan Z to the plan T3, suddenly in 500 milliseconds by telling, okay, I understood the message by the brain.
Okay, but there must be a way to say, okay, well, of course, if it's, there must be a way to say, okay, these are the main fiber tracks that we want to look at and we want to avoid, and these are some of the landmark in the operating theater that you have to look for, and these are the 3 tasks that in this particular location you want to do for neuropsychological mapping. Well, otherwise it gets difficult to replicate the Dufault program elsewhere.
If the surgeon is telling, I would like to see the DTI, red, blue, green, and to select with my neuropsychologist 3 tasks accordingly, you will not succeed.
Well,
because the dynamics. I really insist about that.
Well, but the dynamics are now seen in the operating theater.
Of course, I can see modification of the brain.
But then you're saying you're doing functional mapping before to map the region, looking at remodeling of the plasticity?
Yeah.
So you're doing an fMRI before the surgery?
It's exactly what I did with Bernard Mazoyer 25 years ago. Before and after surgery, but also during surgery, I published a paper with modification of the map.
Yes,
and
but one thing is to publish a paper, and one thing is to run clinical operations. Right? One thing is, let's suppose that we want to run an efficient neurosurgery program that is doing brain surgery using some of the principles that you have beautifully illustrated. I'm the manager of the Neurosurgery Department. What do I need to get? Do I need to get an fMRI scanner? Do I need to get a DTI? Do I need to get a neuropsychologist trained in neuroscience? What are the elements of a program like this one?
For me, when I arrived to Montpellier to answer concretely your question after 10 years in the Saint-Pétri hospital, I said never I will look at the fMRI, DTI anymore before surgery. I will analyze a posteriori of my research purposes. So never, first of all. Second, I have to benefit from beautiful cognitive assessment before, during, and after by having neuropsychologists and speech therapists all doing a neuroscientific program, period. Third, I need to continue to follow the patient, which is also the feedback. You know, the brain is processing lines. And by telling what I did, which was not so good. And it's not done by the vast majority of neurosurgeons I know. I mean, they apply a plan, they succeeded, so everything was perfect. And in fact, no, you have to modulate a posteriori this plan according to the neuropsychologist telling you, you know, you are a great neurosurgeon.
Longitudinal assessment are very critical, yes.
And especially many years later, you know, I'm still alive, thank you so much. They told me that I will die, no rare chemotherapy and working full time, but I'm sorry, I am really now much more irritating. So you have to say at that time why. And to continue to learn. And your surgeons are telling, of course, we learn from mistake. No, they are speaking about, I cut the pyramidal pathways, that's it. But not this kind of feedback, allowing you to build, this is the last part of my answer, new model of cognition based on the truth, dynamically, because DTI cannot give you this kind of information, and to make this model able to evolve. For instance, my paper in Nature Reviews is totally obsolete. 10 years later, the direction is good. But for the vast majority of neurosurgeons, when I show this slide, I published in Nature Reviews.
So just to push a little bit more this argument. So in Padua here, we have a model where the patient is diagnosed by neurologists, usually, or operated by neurosurgeons, and then is given to oncologists, and are the oncologists that are doing the long-term follow-up. How do you see that model vis-a-vis kind of what you present?
To be honest, I decide for neuro-oncologists since 25 years because they cannot see the world.
Okay.
So when they will irradiate exactly the patient we discussed about 72, I do not say that it was wrong to do a Stutt. I say just they apply a protocol because the new classification finally it's a glioblastoma line. I say no, you can discuss according to what the patient wants, and they will ask you, but how do you know that? Because you see the SLF2, because it's exactly what I say in the tumor board. And the vast majority now, we're trained also in cognitive neuroscience, and my radiotherapists are the first to say, I will not irradiate, it's too early. So we are not following the protocols.
I agree. I've been training in neuroscience.
Most of all, radiotherapists, they do not want.
More questions. We're almost done here. 7 o'clock.